Hello, and welcome to Case Study Insights. My name is Katrina Sanders, and I will be your host throughout this 1 hour web-based on-demand program in which we're going to look at the ways in which we, as dental hygiene students and dental hygiene faculty, can take a look at case studies in a relatively different light. During this program, we're going to be looking at how to think like the exam. So during the case studies portion of the National Boards exam, it is important to know that there are very specific differences between the case studies section, as well as how we approach the simply scientific STEM-based questions. And so this 1 hour guided breakdown is really designed specifically to help prepare how to look at or consider these case studies in a critical way. So we're going to look at how reasoning, interpretation, and clinical decision making play a role, because the reality is we know that this is not about memorization, that this really starts to align with both the art and the science of dental hygiene. And so success in being able to scrutinize case studies allows us as practicing clinicians to then apply that information to how we treat our unique patient cases. Let's take a look at what specifically makes case studies so unique and different. Case studies are a really terrific way to employ critical decision-making modalities. They take into consideration realistic patient scenarios. So if you are a dental hygiene student, these are going to be examples of patient case scenarios that you are experiencing inside of your clinical care alongside your faculty. If you're a faculty member or a practicing clinician taking this programmatic content, you know these are really terrific ways to acknowledge how we can apply evidence-based practices into the realistic everyday patient scenarios that we find ourselves in. So this really provides us with an amazing opportunity to take a look patient by patient at what these unique patient needs may be. We'll find throughout the patient cases that we're going to be looking at that while there's one specific patient, that multiple questions are going to come out of that patient experience. And this requires us to have a strong breadth of knowledge and understanding in medical and dental histories, the interpretation of the provided radiographs or photographs. These could also be study models that we may have provided to us. How to interpret comprehensive periodontal charting. So we're going to get examples of different kinds of periodontal charting, which may be complete in nature, it may be incomplete in nature, as well as looking at the clinical findings. So we will see case studies providing descriptions of patient findings, and we'll need to employ or identify what those findings mean as they are relevant to our clinical decision making. Always looking back at patient goals, and I cannot highlight that enough. Both as dental hygiene students and as practicing clinicians, motivational interviewing, identifying what the patient's goal is, what their motivator is, and how to support our patients in that becomes really critical. For dental hygiene students, the examination measures your ability in order to comprehensively walk through the dental hygiene process of care. So ADPI, your assessments, your diagnostics, and subsequently how you interpret all of those diagnostics into, of course, being able to plan, implement, and subsequently evaluate the success of your care. So this is the challenge of integrating and employing case studies, is that it's not a recalling of facts. It is not raw memorization, but rather the integration of critical decision-making for patients. For dental hygiene students preparing to take a boards in which they are looking at case studies, Please know that you will be expected to look at, or rather identify, major differences between what's considered normal versus abnormal. So they want you to know this does not look correct. We want you to be able to interpret or identify various radiographic findings and subsequently be able to compare those radiographic findings with periodontal measurements. You should be able to take all of the data that you have and utilize that data in order to determine classifications and subsequent severities of disease. You should also be able to prioritize patient care based on not only the findings that you have, but subsequently their medical status. So this, again, is going to lean back on or leverage your understanding of medical conditions, identifying when it's appropriate to employ things like maybe doing a med consult before you would provide care to the patient. What are going to be some of the red flags that we want to keep our eyeballs on? And along the way, we need to be able to employ evidence-based clinical judgment. At the end of the day, the goal of the Joint Commission, the goal of taking our national boards exam, and quite frankly, the goal as practicing clinicians is always to make sure that we maintain our ethical professional standards and that we do so inside of the code of ethics that have been established for us as clinicians. So safe, effective, ethical, fair dental hygiene care to our patients is going to remain the cornerstone of how we deliver care for patients, and subsequently what our decision-making modalities are inside of how we approach case studies. So for those of you who are preparing to take the national boards examination, it is important to know that you will have various types of patient cases being distributed throughout the exam itself. About 80% of the cases that you'll see will be adult patients, and about 20% of those cases will be child or adolescent patients. And it's important to know that for the most part, the cases that you should be prepared to approach are not necessarily going to be easy cases. At least 2 of them will have a medically compromised scenario of some sort where you're going to need to be able to demonstrate acumen in measuring, managing, or mitigating that medically compromised issue. In addition, please also know that you're going to see a variety of patient cases that are going to have various oral health challenges. So you're going to need to manage things like pathologies, caries issues. You're going to need to manage things like periodontal or oral inflammatory conditions. And so that becomes a really important cornerstone as far as where we need to make sure that we're focusing our acumen. It is important to know that there will be questions or adjudicated pieces around diseases of the periodontium, caries, and specifically preventive strategies, high risk or special needs patients, and then infection control modalities. When we look at patient cases, there are various types of data points that we analyze, whether you're taking this as a test or whether you're taking into consideration patient cases that you're approaching as a practicing clinician. And these are things that we have to take into consideration. Understanding or taking into consideration these various factors means that we might have indications or contraindications that are very specific. So I promise we'll dive into each one of these one by one. As an overview, a few things that you really should be starting to put your eyeballs on as you begin approaching cases. The first is your demographic data. What is the age of the patient, the sex of the patient's chief concern, and let's start to pull out those risk factors. When you look at cases, particularly in preparation for the national boards, those will be well listed out in the STEM. They might be hidden, but once you start getting good at looking at how cases are aligned, you'll start to see them pop out a little bit more. One of my favorite examples is your typical anorexic patient. Demographically, the data that we typically see when it comes to, and this is just an example of an anorexic patient, is going to be a high school aged, underweight, young, high achieving female. And so in the STEM, you might, meet Kayla, who is a high achiever. She's captain of the cheerleading squad. She is, taking all advanced honors classes. She's going to spend her summer vacation going to Harvard and learning about women in STEM. She has overbearing parents who come to all of her appointments and make sure that she stays on top of things. She's extremely meticulous with her home care, and so you're going to start to see some potential nutritional deficiencies going on. And although the national boards may not call it out, they want you to be prepared that this may be an anorexic patient. And I say this because in the clinical world, for those of us who are practicing and seeing patients, it is quite rare that a patient will come out and say to us, yes, I am suffering from anorexia. It is our job to start to kind of put those puzzle pieces together. And so age, sex, risk factors, some of those things we're going to start to kind of put together in that giant ball of wax to identify, could this potentially be a case, right? So there's your demographic data. And again, I promise we'll go through one by one on these. Medical histories. So looking at the reported systemic conditions, the medications that the patient is taking, and their vital signs. I say reported because be prepared. This happens on the national boards exam. This happens in clinical practice. Patients may have a systemic condition, but they don't know they have it. So we can see this in underlying conditions, risk factors, maybe even potentially a medical emergency that may happen that may point to, okay, you might be a diabetic and you didn't know it. We need to know our medications. We need to know the generic names of our medications, side effects of those medications. We need to know, potential indications or contraindications, medications that are not going to play well in the sandbox together. So we need to be prepared for that. And then vital signs. What are concerning vital signs that are going to stand out to us and say, something is wrong? Again, there may be some kind of an underlying condition or we might be prepared for a medical emergency. Dental history and charting. So now we're going to take a look at that dental charting. We're going to look at the existence of restorations. We're going to look at the patient's caries risk based on the factors that we have within the STEM. Occlusal status could be provided to us or through study models, things like that. We also want to look at perio charting. So probe depths. Is there clinical attachment loss? Have they charted bleeding upon probing? Are there recession sites? And we're going to use this information to help determine the complexity, severity of disease, the rate and progression of disease. This might also give us information about appropriate interdental aids or appropriate home care tools that we may want to employ. Radiographically, we're going to look for bone levels. We're going to look for the presence of radiologic debris. This is where we may be even analyzing potential radiographic lesions or pathologies, furcation involvements, things like that. And again, please always know, we're going to go back to that cornerstone of the patient's goals. Motivational interviewing is extremely important when it comes to aligning our treatment plan modalities with patient needs, as well as what are the patient's barriers to treatment, because part of our role as patient advocates will also be, how do we work through those barriers? Sometimes those barriers are psychomotor. The patient cannot hold their manual toothbrush. And so now we're going to talk about recommendations for other options for our patients. In other cases, it may be cognitive. The patient has a low dental IQ and we need to counsel them on this. In other areas, it may be lifestyle. The patient has poor dietary habits, or the patient's a tobacco user. Sometimes those barriers are, public health related. And so access to care and things like that may kind of employ within. So looking at the patient's fears, their finances, their compliance literacy, and things like that. So what we're going to do is walk through analyzing the data, and we're going to do just kind of an overview. This, my hope is, will provide a really dense opportunity to scrutinize, from each of these types of data set points that we're going to be looking at, where do we need to move our eyes, and subsequently, what do we need to be prepared for when it comes to approaching patient cases? So again, the first is going to be your demographic data. Again, your age groups are really going to tell you a lot about the type of dentition you're going to be looking at, and subsequently fluoride tolerance. So know that a child under the age of 6, we're looking at varnishes only. We don't want to do anything where the pediatric patient could theoretically swallow the fluoride, and we're looking for early childhood caries patterns. From ages 6 to 12, now we're looking into that mixed dentition, and typically we're going to start to see some eruptive gingivitis going on. Those eruption patterns are going to be really important. We may need to take a look at a pano and identify the potential age of the patient. And oftentimes, right when we start to get those 6-year or 12-year molars coming in, we're preparing for sealants. In adolescence, we want to be prepared for those hormonal shifts and an increase in patient autonomy. So now mom or dad are probably not performing self-care on these patients. They're probably delivering their own home care, which brings alongside it oral hygiene complications or potential complications. We need to be prepared for diagnosis associated with puberty, like puberty gingivitis, orthodontia, and the potential need for interdental aids or self-care aids for ortho appliances, the complications of high-risk snacking. And again, motivational interviewing is going to be an amazing opportunity here. In our adult patient demographics, we're going to start looking at risk patterns. So caries risk, periodontal risk, systemic health, lifestyle factors, etc. And yes, you will likely see a geriatric or older adult case where xerostomia is an issue, polypharmacy, or taking multiple medications, and now potential interactions with those medications may be an issue. We're going to need to be prepared to manage things like root caries, recession, dexterity issues, xerostomia, and of course, we're going to look at combo of fluoride and subsequent xylitol support. Gender is also going to be a potential driver here, so we need to take a look at hormonal or systemic modifiers for your female patients. Get ready for pregnancy with elevated, inflammatory responses. Your bug of choice there is either going to be Prevotella intermedia or Campylobacter. Your pregnant patients who are on oral contraceptives, be prepared. We're going to probably see some increased gingival bleeding. Your female patients going through menopause are going to be experiencing things like burning mouth syndrome, osteoporotic issues with potential bone level changes, and then your bisphosphonates likely to manage those osteoporotic issues. So again, stay tuned for that. Males, we know that the male gender has a higher prevalence of periodontal disease. We do believe that's because they're typically a little bit less compliant with home care than our female patients. So just be mindful of that. And again, in this demographic area, please keep your eyeballs on pregnancy limitations. So tetracycline class antibiotics, nitrous oxide, NSAIDs, so ibuprofen, etc. We want to be really careful with. And then the chief complaint, knowing that chief concern is really important because it's going to help you to identify what the patient values. And again, from a motivational interviewing standpoint, knowing what the patient values is going to allow you to be more patient supportive in your care. This is important for national boards because addressing the chief complaint is going to be extremely critical. But in the clinical world, for those of us who are licensed in treating patients, this becomes even more important when it shows, or rather gives us the opportunity to demonstrate that we do care about aligning our work, our patient care plan alongside what matters to them. So we always want to watch for what that chief complaint is, what they're saying or what they're noticing. My gums bleed when I brush. Perfect. Well, not perfect. We don't want that. But when the patient's gum tissues do bleed and they notice that and they're telling us, great, now we can build out a plan where the first step in this process is going to be focusing on those assessments and inflammatory management. Conversely, we could also get a chief complaint where the patient says, I'm kind of embarrassed about how my teeth look. And this is where we would perhaps want to consider driving home aesthetics, whitening. And I will say, this patient may also have active periodontal disease. So I don't mean to say that we're going to whiten their teeth first and let that periodontal disease linger. But I do mean to say we should be talking to the patient about how treating the periodontal disease is an important aspect of aesthetics. And that while we do have concerns about whitening teeth and things like that, we want to make sure that the periodontium is stable first. That becomes a critical aspect of their aesthetics. I'm nervous at the dentist. Okay, if the patient mentions they're nervous, we need to be prepared with management strategies like tell, show, do. Maybe we're going to use desensitizers, anesthesia, nitrous oxide. We need to be really prepared. For those of you preparing to take the national boards, the correct board answer is always the one in which you're addressing the chief complaint, you are supporting the patient's own autonomy, and you are using the least invasive, clinically effective approach first. And that really delivers an opportunity for us to be really supportive of our patients. So again, for example, my gums bleed when I brush. So we want to make sure that we are addressing that chief complaint, that we are supporting their autonomy. So yes, we know that a critical aspect of addressing gum bleeding is going to be probably doing scaling and root planing or some kind of procedure in office. But we want to talk about patient autonomy. So what are the things the patient can do to manage a lot of those things? Employing the use of electric toothbrushes and delivering self-care becomes really important. And this starts the journey. We may not be able to begin SRPs right away. Patients here for a new patient exam. But we can start giving them tools today to start delivering self-care, autonomous self-care that is non-invasive until we can get them back in and get them scheduled for their SRPs. So the question may say, the patient is scheduled for a new patient exam. They're scheduled for 1 hour. You don't have time to do treatment today. What is the most important use of your time with this patient today? And the answer would be probably, show the patient how to use an electric toothbrush and dispense an electric toothbrush for them to begin using, reappoint the patient back for active scaling and root planing, right? Finally, looking at demographic data, we really want to make sure that we're actively looking at risk factors. And these risk factors, stay tuned, they're going to come into play when we look at diagnostics. But these risk factors are going to help us to predict the severity of disease, the progression of disease, and predict our outcomes. So on the relevant side, for example, if our patient was a tobacco user or they were a diabetic, we could theoretically predict that their successful outcome around surgery or around non-invasive scaling or non-surgical SRPs may not be as good as a non-smoker. So we would want to let the patient know that one way to help improve their outcome could be quitting smoking and or controlling their diabetes, right? High caries diet pattern, so a high glycemic index diet. Well, gosh, we're going to spend all this time drilling and filling all these teeth and giving you fluoride. Your ability to control your diet by making simple changes could theoretically help improve the outcome of your caries treatment. And that goes for things as well, like poor oral hygiene or plaque control, stress, both physiologic and behavioral becomes really important. Low socioeconomic status or access to care, alcohol or substance abuse, multiple medications. Some of these things we can control, some of these things we can't control, but we can educate our patients about the fact that these are complicated factors, and we can put into place things like, hydration therapy, xerostomia mitigation strategies, xylitol therapy, fluorides, hydroxyapatites, etc., stannous fluorides to really help support our patients. And I've got some exam tips here just to kind of, trickle out a little bit of important information. So this is going to really kind of lean into the diagnostic side of things when it comes to staging and grading, but know that a patient who's a smoker, in the periodontal disease is automatically going to be a grade B. And if they are smoking more than half a pack a day, they're going to go up to a grade C, regardless of the amount of bone loss. So there are risk factors where it doesn't matter whether we're seeing aggressive bone loss or not, because you have this risk factor, we can predict that your rate of progression will probably move faster. Then we move on from those demographic studies into looking at medical status, beginning with that medical history. And this is just a very brief overview of some of the more common types of systemic conditions or key clinical red flags that we want to be prepared for. Beginning with diabetes, be prepared. A significant portion of our patients are poorly controlled. We know that we can ask for vital signs of a hemoglobin A1C or a fasting glucose to be able to identify. We know that if that A1C is over that 7% mark, that we should anticipate a slower response to therapy, delayed wound healing, the pervasiveness of periodontal inflammation, and we should also be prepared for a potential medical emergency. Okay, start thinking about what's in that emergency kit for these patients. Hypertension. Depending on how severe the hypertension is, and we'll take a look at this in a second, depending on how severe that hypertension is, we want to avoid vasoconstrictors. Again, depending on how severe. In just the elevation, we may not necessarily be avoiding vasoconstrictors, but if it is excessively uncontrolled or the patient is in a hypertensive crisis, we absolutely will not be delivering care to the patient. Anticoagulants, like warfarin, for example, in the past, we used to stop that medication for routine hygiene visits. We don't anymore. And yet some of these medications, like warfarin, we could get an INR level, which is a clotting factor time, or a prothrombin time. Others we may not be getting an INR level for. So again, we would want to go back to understanding our pharmacology for that. Asthma. I cannot stress this enough. Avoid aspirin and non-steroidal anti-inflammatories like ibuprofen. So your acetaminophen is going to be your drug of choice for pain management for an asthmatic, because aspirin or NSAIDs could trigger an attack. You want to make sure that you're employing stress reduction, have an inhaler accessible, and be prepared for a potential medical emergency. COPD and emphysema, big indicator here. Make sure that you are avoiding nitrous oxide, because oxygen demand is really important for a COPD patient. When you're putting them on 100% pure oxygen, that oxygen demand can actually complicate their CO2 oxygen levels. You also want to avoid putting them into a supine position for a very long time, having those lungs lay flat. So a semi-supine position, partially seated up, is going to be important. Pregnancy, again, make sure that we're looking at the pharmacologics here, avoiding tetracyclines, non-steroidal anti-inflammatories, and nitrous oxide. The data is kind of changing here, but according to the national boards, the second trimester is probably the best window for routine care, but it doesn't mean that we would decline a pregnant patient from receiving care outside of that window of that second trimester. Here are the current American Heart Association BP guidelines and the clinical action associated with those subsequent guidelines. So if our patient is under 120/80, we're able to proceed as normal. If they move into 120 to 129, still that diastolic under 80, we want to just reinforce that lifestyle education. So we want to talk to the patient about, maybe moving from a sedentary lifestyle, reducing sodium intake, things like that. Stage 1 hypertension begins at 130 to 139 over 80 to 89. It can be either or. And here at this point, we want to make sure that we actively monitor. So you're going to take that BP again. And if there are multiple risk factors that all kind of point to potential cardiac issues, you'd want to limit epi to that cardiac dose. Okay, 0.04 or 0.2, depending on if you're using epinephrine or levonorepinephrine. Stage 2 hypertension is going to be at or above 140 or at or above 90. This is where if the patient is completely untreated, so no physician knows about this, is providing any kind of care whatsoever, you want to make sure that you're sending a consult and you're going to proceed with extreme caution. By the time the patient goes into hypertensive crisis, you are immediately stopping, and you are not touching this patient. You are immediately referring them to an emergency care unit to be addressed. That's 180 or above, over 120 or up or above, and it can be either or. Other vitals that we look at are going to be heart rate and respiratory rate. Please keep your eyes on the differences here in age. So your newborn heart rate is going to be anywhere between 100 to 160, and that's going to be normal, which seems excessive for a newborn. The child, that starts to slow down as we age. So child around 70 to 120 beats per minute, and then your typical adult anywhere between 60 to 100. Which means if your patient is outside of these, either extremely slow or extremely quick, we need to be prepared for a potential medical emergency. Same deal with respiratory rate, newborns 30 to 60, breaths per minute, a pediatric or child patient 20 to 30, adults are about 12 to 20. Again, if we are outside of that, either excessively slow, more concerningly, excessively fast, we need to be prepared for hyperventilation. So just know on the board tip side that a pulse or respiration just outside of normal oftentimes indicates anxiety for the patient, not necessarily the activity of disease, and look for patterns for the patient. Every time they come in, they're elevated, so they probably have some anxiety associated with being in the dental office. In the medical arena, the final piece that we want to make sure that we have a good acumen around is ASA physical status. And ASA classifications are 1 through 5, 6-ish. A patient who's considered an ASA 6 is a patient who is going to be deceased within the next 24 hours. They are on life support. They're likely on life support in order to maintain their organs in preparation for organ donation. And just to be very clear, you should not be seeing in a dental setting a patient who's an ASA 5 or 6. However, we can see patients who are ASA 1 through 4. An ASA 1 is going to be a healthy patient who demonstrates no systemic disease and no drug allergies and is not pregnant. An ASA 2 will be mild, so well-controlled systemic disease, so hypertension or diabetes that is controlled. Your pregnant patient will automatically go to an ASA 2. A drug allergy patient will automatically go to ASA 2. ASA 3 is where the patient has systemic disease and now it's poorly controlled. So a diabetic patient that's poorly controlled, hypertension poorly controlled, a stable angina case will also be considered an ASA 3. ASA 4, now the patient has severe systemic disease that is life-threatening. So the angina is unstable, recent myocardial infarction or TIA within 6 months or less. So we want to make sure that we keep an eyeball on those because ASA physical status gives us a lot of information about the patient's ability to withstand dental care. Let's move on to hard tissue. Looking at our caries classifications, beginning with our GV Black, yes, we should know what a class 1 through 5 is. We know class 6 was actually added about 100 years later. Class 6 is when you see those incisal edges or the cusps having decay inside of it. That's typically associated with wear, parafunctional issues, and age of the dentition. But please know how to locate and subsequently identify what a class 1 is. So that's going to be, of course, your pit and fissures. Class 2 are the proximal surfaces of your posterior teeth. Class 3, those are going to be your proximal surfaces of anterior teeth in which the incisal edge is not involved. Class 4, proximal surfaces of anterior teeth in which the incisal edge is now involved. And then, of course, your class 5s, that's going to be along that cervical, facial, or lingual surface, typically associated with abrasion, abfraction, acidic diets, things like that. Okay. Know that if the radiographic interpretation shows a radiolucency that's only inside of the enamel, you're going to call that an incipient area where remineralization is indicated, not delivering a restoration. So we want to know how far is that decay moving. We also want to make sure that we're scrutinizing caries risk assessment. So, what is going to drive the patient's presence of their caries risk? So, I want to be very clear. Risk is not, does the patient have decay? That's not caries risk. It's about identifying what is the cause of, or why is the patient experiencing the occurrence of decay. So, we want to look for things that are going to be good high risk indicators. Number one, the number one is frequent snacking and sugary beverages. So we want to elicit that information from our patient, and or it may be in the case study stem. The patient says things like, I work for Coca-Cola and I sip a 6-pack of Coca-Cola all day. I have a 12-hour shift, and sipping Coca-Cola through my day is what gets me. Okay, that's a pretty good indicator that this is what's accelerating high risk associated with decay, right? So that's number one, fermentable carbohydrates and constant exposures of those fermentable carbohydrates. But we also want to look for other risk factors. Those will be things like dry mouth, so the presence of medications, and polypharmacy being multiple medications and increasing dosages of medications. Sjogren's, radiation therapy. There are also medical conditions that will elevate the risk of dry mouth, like diabetes, for example. Plaque retentive things like orthodontic appliances, right? So once the patient's in bands and brackets, plaque is going to stick everywhere. So we need to be careful and mindful of that. Deep pits and fissures, low fluoride exposure. So the patient may be in a community where they have low exposure to fluoride, or they're not using a fluoridated toothpaste currently. That is, as of the current moment, considered a risk factor for caries risk. And then a history of recurrent decay. So areas where restorations have failed and new restorations have needed to be placed because of recurrent decay, we want to make sure that we're being mindful of that. Factors that we should be considering, or tools that we have in our tool bag to consider: fluoridated toothpaste, delivery of professional varnishes, delivery of xylitol or other types of saliva stimulants, pit and fissure sealants, encouraging the use of water in a baby bottle over sweetened beverages, and certainly diet behavioral modification is going to be really important. So a few things to take a look at. And on the clinical acumen side, the risk patterns are going to be, and oftentimes in combination, can tell us a lot about where we would prioritize ourselves clinically. So here are just a few short, easy peasy examples. Teenage patient with a soda habit in orthodontia. Okay, so we've got acid exposure on that, kind of smooth surface area, and then we have orthodontia or plaque retentive, bands and brackets, high risk. We want to talk about sealants, fluoride varnish, and then dietary counseling. Meanwhile, we could have an elderly patient. This elderly patient has, exposed root surfaces and they're on 5 or more medications. Okay, well, that's a little bit different. That risk pattern is associated with now root caries, right? Exposed cementum. And the concern here is, saliva support, doing salivary stimulation, and putting the patient on a higher dosage of fluoride toothpaste. Conversely, we could have a patient who's a toddler. Mom puts the toddler to bed with a bottle that has fruit juice in it. Now the risk pattern we could theoretically see is that early childhood caries, where our clinical priority is going to be focused around fluoridated varnishes and then education for mom or dad, right? So taking a look at the presence of how these risk patterns show up, the scenario, and then looking at, okay, so if this, then that, if this, then that. It is important to know that a patient with active decay right now will automatically be classified as high caries risk, regardless of if they're doing things like fluoride varnishes or if they have sealants. If they have active decay right now, they are high caries risk. A few other things to look at hard tissue wise. Occlusion. Let's not forget our angles classification. So your class 1 or your normal angle classification, mesiobuccal cusp of that maxillary first molar aligns with that buccal groove of the mandibular first molar. Second classification is retrognathic. And retrognathic, we can have division 1 and division 2. And that's where the maxilla is forward, mandible's back, and we can actually get that overjet or overbite. Class 3 is considered prognathic. That's where the mandible is now forward, that underbite. I've got a pug mix tootling around here somewhere. He's got that typical class 3 prognathic pug bite, right? That underbite where the chin appears quite prominent. And again, make sure that you can differentiate between overjet, which is that horizontal distance, versus the overbite, which is that vertical overlap, right? And then taking a look at how some of the parafunctional habits a patient has may point to or be an implicator for malocclusal issues. So a good example of this could be an open bite. Oftentimes, patients who have an open bite, that came from overt thumb sucking, where the thumb actually pushed out, created a major overjet, or this could be a potential tongue posture airway related complication. There's a tongue thrusting that's happening that's pushing out that open bite. Edge to edge, we're going to see incisal wear or fracture risk associated with that. And then be careful with crossbite. This is where there may be an imbalance in the development of that masseter muscle. And so unilateral mastication and potential digestion may be an issue. So for a tip, just know that if occlusion contributes to the display of tooth wear, recession, and abfraction, know that one of the ways that you're going to address that is through managing those occlusal forces, perhaps doing aligner therapy or orthodontia, maybe giving the patient a night guard, not having the patient brush softer. Okay, we want to take a look at the cause and subsequent effect. Let's move on to perio. Looking at staging and grading. Gosh, this is like a 5-hour workshop in and of itself. For those of you who are preparing to take the national boards, please know that they are not trying to trick you, and they will do their best to be as clear and concise as possible about the stage based on things like radiologic bone loss. So again, you want to take a look at bone loss based on how much of the root is covered in bone versus not covered in bone. You're going to look for clinical clues like those probe depths are going to be pretty good indicators. And the major differentiator, of course, between stage 3 and stage 4 is the subsequent number of teeth lost due to periodontitis. Alongside the staging, which is the severity, looking at things like the presence of clinical attachment loss, bone loss, and the complexity of disease, we also have the grading, which is the rate of progression, integrating things like risk factors or how much bone loss has already occurred for the patient. Okay. Now, in the grading area, it is important to know that we're going to look at how much bone loss has already occurred while also employing two major factors, tobacco status and diabetic status. Grade A is slow progression, grade B is moderate, and grade C is going to be your rapid rate progression. And it is important to know that most of your general adult perio cases are going to begin in grade B. We're going to default at B. And if nothing else suggests it, they'll stay in B. However, if the patient has a healthy lifestyle, they have stable bone that hasn't moved, they're a non-tobacco user, a non-diabetic, we can move them up to that grade A slow rate. Conversely, the patient's at a B already. We've started them at a B. If the patient is an uncontrolled diabetic or an active tobacco smoker, we're going to go ahead and move that patient to a grade C. We shouldn't need any math to help us with that. So we need to take a look at stage, how much damage has occurred, and then grade, how much damage is happening over a spectrum of time. How likely is it that this damage is going to progress based on risk factors like tobacco status and uncontrolled diabetes? Okay, we're going to take a look at radiographic interpretation now. And it's important to know from radiographic interpretation that we have different modalities that we're going to take a look at. So, radiographic interpretation, we should begin by looking at bone levels, calculus, and furcations. This is going to start the journey. After we look at bone levels, calculus, and furcations, so a periodontal radiographic interpretation, then we're going to move into pathology and subsequent restorations and margins that may be key contributory factors. But this is where we start. Okay, bone levels. Let's begin there. Normal bone is going to be anywhere between 1 to 2 millimeters from the CEJ. We want to have that natural biological width, or as they're now currently calling it, supracrestal attached tissues. Horizontal bone loss, we're going to have even reduction of that bone. Vertical or angular, we're of course going to see more aggressive progression, V-shaped chips of bone out of various localized areas. And again, you want to make sure that you're looking at a good, high quality PA. You want to split that root into thirds, and you want to know where within the coronal, the middle, or the apical third are we seeing that bone level. That's going to tell us about where we stage that patient. Calculus is going to be a bit more visible on bite wings than we'll use for PAs, for example. And calculus, we know, are going to be radiologic spurs or, little triangles along those root surfaces. Heavy calculus, please know, is a contributory etiological factor, but it is not a severity indicator. So just because your patient has radiologic calculus does not mean that you move the patient from a stage 2 to a stage 3. That's not what we're going to do. So severity is based on the amount of bone loss and or clinical attachment loss, not the amount of calculus that's there. Okay. Furcations, those are best seen on maxillary molars and mandibular molars. We're going to be able to see those radiolucent triangles through root divergence. Maxillary, we're going to see the mesial and distal furcations a little bit easier, a bit hard because you got that giant palatal root there that blocks that buccal furcation from being visible on radiographs on the maxilla. So know that we can oftentimes see furcation involvements. By the time you see them radiographically, they're probably pretty involved. And then we've got our pathologic radiographic interpretations. So this is where we are looking for the presence of abscesses, granulomas, and cysts. Based on key features like what does the border look like? Is it a diffuse border? Is it well circumscribed? Is it defined? Does the patient report pain? Is it chronic? Is it asymptomatic? Is it slow growing? Is it round or oval? And there are a whole host of relatively common radiolucencies or radio opacities that we can see that have with them quite iconic patterns. When it comes to radiopaque findings, calculus is radiopaque, sclerotic bone is, and then tori or exostoses are as well. So again, knowing the pattern of how radiologically these pathologies or findings are showing up will be really important as well. So on the radiographic exam side, make sure that you're looking for bone levels, calculus, furcations to begin, then look for your pathologies, conclude with restorations and margins that could be key contributory factors. Okay. We're going to round out our conversation here by talking through the cornerstone of how we should be approaching patient care, whether this is as a dental hygiene student preparing to take the national boards where you want to make sure you're answering the questions correctly, or whether you are a practicing practical clinical dental hygienist delivering care to patients in a clinical setting. Patient goals and subsequently the value that patients place on their oral health care is really critical. Put simply, if the patient doesn't value oral health, we're going to put treatment options in front of them and they are going to use their autonomy to say yes or no based on that value or subsequently the lack thereof. So before we choose a treatment plan, we need to ask, what does this patient care about? And I don't mean to say that a patient comes in and sits down and they've got stage 4 periodontitis and all they care about is whitening. So the only treatment plan we're going to put in front of them is whitening trays. I do not mean to say that. But what I do mean to say is we need to make sure that we are looking at what the patient's chief concern is. Again, we need to make sure that we begin by using the least invasive, effective approach, and that we respect the patient's preferences and subsequent autonomy. So let's take a look at a couple of examples here. Right away, let's say that the patient's goal is they notice that there's bleeding and there's inflammation. And so they say that, I've noticed that my gums are starting to bleed a little bit more when I brush my teeth at night. We know clinically that could mean a gingivitis or a perio problem. And this is where we're going to begin by focusing on biofilm disruption and oral hygiene first. Then we might move into scaling and using medicaments as indicated. So again, least invasive approach. We can't start SRPs today. Patient's only here for a new patient exam. What are we going to do? We're going to start with biofilm disruption, oral hygiene, get an electric toothbrush, get the right kind of paste in our patient's hands. Maybe they want to improve their appearance. So clinically, this could mean they've got staining, crowding, enamel defects, etc. So, we want to make sure that we're being conservative with those aesthetics. So, polishing, minimal intervention. We could also let the patient know once your dentition is stable, we can do whitening, things like that. Let's say the patient says, my teeth are really sensitive, right? And so my concern is addressing that sensitivity. Oftentimes we know that sensitivity is pointing to either one or a combination of things like exposed root surfaces, where that dentinal hypersensitivity is occurring, tooth wear, recession, etc. So now we want to be prepared to offer desensitizing treatments, fluoride therapy, and maybe evaluating the occlusal status of the patient, because if that wear is a contributory factor, we're going to need to address that down the road. Let's say the patient says, I'm really nervous or I'm scared to be here. Clinically, that could mean the patient has a history or previous trauma or dental phobia. So, again, national boards could say, what is, one of the first things that you're going to do to address the patient's chief complaint? And the answer could be doing the tell, show, do technique, shortening appointment times, utilizing topical anesthesia, employing high-level patient communication techniques. Let's say the patient says, I don't really have a complaint. I'm just here because I want to make sure that I'm maintaining my oral health long-term. Okay. Well, what that typically means is the patient is quite motivated and they're prevention focused. So now we know that that patient is motivated to, or they care about things that are going to help them maintain their oral health long term. So that could be preventive modalities like sealants and fluoride therapy, looking at the frequency of their recare systems and looking at risk factors as educational opportunities. It's important to make sure that we look at what barriers are present when it comes to our patient's care. Please know that if there is a barrier that's present, your answer will never be, I'm not going to do anything. I'm going to proceed with treatment anyways, no matter what, or I'm going to dismiss the patient because they're non-compliant. Know that your approach, and again, this is really important, not just for national boards, but for our practicing clinicians, know that our care should really be centered around empathy, behavioral modification, and delivering practical support that aligns with the patient. That may not be achieved in one single appointment. That is why we have a long-standing history of working with our patients. So there are different kinds of barriers that patients can and do present with. Financially, we could see limitations in their insurance, or they'll say things like, I'm really concerned about cost. So maybe we begin by offering preventive therapies, staging their treatment, starting with the most concerning and going one by one, and offering lower cost options. So an example of that could be a patient who reports cost concerns and they've got an option between having the tooth extracted and having an implant placed, or having that tooth extracted and having a partial denture. Partial denture is going to likely be a bit more on the inexpensive side versus a single tooth replacement. So maybe we offer a lower cost option for that patient, right? Fear and anxiety, oftentimes these are patients that are avoidant. They maybe have a bad history of a negative experience at a dental office. They may have even, in this avoidant behavior, avoided the dentist for many, many, many years. So we don't want to, make the patient feel bad and scold them. We want to talk about behavior modification. I'm so glad you're here. Communicate with them. Would you be open to needleless anesthesia or topical anesthesia? We have nitrous oxide. We have ways to help reduce that anxiety, along the way. Low health literacy or low dental IQ. So these are patients that don't understand the disease process. You'll ask the patient any significant changes to your health history, and they say nothing that affects my mouth. A good indicator this patient has low health literacy. So, utilizing simple language, visualizations, introducing teach-back methodologies as a way to help the patient understand that connection is important. We could also experience cultural or personal beliefs. Patients are anti-fluoridationists, or they prefer natural or alternative care choices. And so an effective response is to respect those values, provide gentle evidence, and make sure that we avoid confrontation, but letting the patient know we are here to align with your unique needs. We can have patients that have physical or dexterity limitations, where maybe they have osteoarthritis issues, Parkinson's, they're a post-stroke patient. This is where the use of a powered electric toothbrush, modified grips, like that tennis ball, for example, showing a caregiver or getting them involved in self-care is really important. And finally, dry mouth or patients with high medication burden and polypharmacy. They've got that laundry list of medications. They complain of dryness. Now we want to make sure that we're employing things like saliva substitutes, xylitol, hydration, high concentrations of fluoride toothpastes at home, etc. I want to round out our time today by walking through that sequence of that framework, the sequence for which we answer case-based questions and do so with confidence. So again, today we talked about walking through the demographic identifiers, telling you the clinical lens that you should use in employing care for patients of various ages, genders, chief concerns, and risk factors. Then we look at that medical history, and we want to make sure that we prepare to modify care, safety first always, by looking at medical conditions, medications, vital signs, and ASA classification. The third step is looking at dental and periodontal data as we have it, utilizing that data to establish disease status before we develop a plan. And that's where we employ the charting, probing depths, clinical attachment levels to be able to stage and grade the patient. Step 4, now we're going to take a look at radiographs to determine what that bone loss pattern and level is, presence of things like calculus, furcations, pathologies to confirm our assessments before we answer questions. And number 5, always making sure that we're looking at patient goals and subsequent barriers. What does the patient value? What could prevent treatment success? And let's make sure that we develop a plan that aligns with the real world capabilities of the patient. We want to make sure that our strategy for supporting our patients is associated with making sure that we are clinically appropriate, that we are safe, that we are aligned with our patients, and that we are the least invasive, with evidence-based treatment being that first step. Remember, when it comes to delivering case-based care for our patients, you don't pass case studies by memorizing. You pass them by thinking like a clinician. Now, this case studies portion precedes looking at comprehensive case studies together. So this web-based program is designed to give you the prerequisites for us inside of our live interactive program, where we're going to look at how to read a case study before you answer the questions, how to look at the most clinically meaningful data, how to recognize the distractors that are there, how to approach medically compromised patients, and how to be really definitive and develop a repeatable analysis system that allows you to be effective in approaching cases so that no patient case feels intimidating. My hope is that this overview provided that initial step in understanding comprehensively how to approach cases. My name is Katrina Sanders of Sanders Board Preparatory, and I want to thank you so much for your time in joining me for this on-demand web-based program. I look forward to seeing you in our series where we're going to walk through patient cases together. Thank you.